I changed the title slightly to include side effects because, of course, most of our monitoring is designed to detect side effects or adverse events. And I suppose the monitoring bit of it can be split up into that which we do in clinic and that which we teach parents to do at home. And there are some side effects that we look for that occur in the short term and are quite serious but manageable. And there are other side effects that we look for in the longer term which can be serious but are also manageable. So I think the take-home point is that although there are side effects associated with this treatment, we can manage those. I suppose the one that creates most anxiety, especially in the early days, is that of low blood sugar, hypoglycemia, and too many ketones too quickly. And there was a study in 2005 that looked at the introduction of the diet over a 24 to 48 hour fasting period and then moving straight to a 4-to-1 ratio, compared in the other group with a gradual introduction of the diet. And if you look here, you can see that in the fast group, 0 on day 2 with 0 calories, and then straight to a 4-to-1, compared with a gradual onset of the diet. And what they found was that hypoglycemia, low sugar, occurred in 33% of the children who were introduced on the fast regime or regimen, and only 4% of those with the gradual regimen, and that excess ketones were found in 63% of the children in whom the diet was introduced very quickly, compared with only 29% in those who had a gradual introduction of the diet. So what this really tells us is that slower can be equally efficacious, and it was equally effective in terms of effect on seizures in that study. But it's also safer and better tolerated by the children. It goes without saying that all families should have an emergency care plan from the beginning for how to deal with this complication should it occur. A more recent study has been published from the Johns Hopkins group, and they are the group who traditionally fast children before introducing the diet. And they looked at their complication rate during ketogenic diet initiation. They had fasted children for 18 hours in 80%. The other 20% had various reasons for why they weren't put on the fasting regimen. And they used a combination of a 3-day and a 2-day initiation period. They described hypoglycemia in 28% of the group as a whole, but found that fasting was only associated with increased risk of hypoglycemia in the children under 2. They also found that fasting was associated with increased lethargy. And they concluded that fasting should be avoided in children under the age of 2. Our practice in Newcastle is to admit children under the age of 2 or for any other special indication, but we start all other children as outpatients, and we would use a gradual introduction of the diet whether we admitted children or not. Moving on to other short-term and common and manageable complications, the most common of these is gastrointestinal disturbance. And that's true in most of the studies that you look at. Constipation, I think, is the most common one of those, but that is, quite easily manageable if you stay on top of it. In my experience, I haven't seen vomiting as common as 36% or 24% in our group. And we haven't had a lot of difficulty with diarrhea. I would say constipation is the most common thing that we see. However, all have been described on various forms of the diet. You can see that classical MCT and modified Atkins diets are all represented here. In terms of the longer-term side effects, perhaps renal stones and thinning of the bones are the most common, with cardiomyopathy and pancreatitis being quite rare in comparison, and we'll talk about each of those. So the incidence of renal stones for individuals on the ketogenic diet is higher than the general population. The percentage varies, as you could see from the previous slide, with the upper limit of the prevalence being about 7%. You get all types of stone, urate, oxalate, phosphate stones, and there is the potential for this risk to be increased with the use of carbonic anhydrase inhibitors, such as topiramate and zonisamide, anticonvulsant medications. In order to keep children under surveillance for this complication, we would dipstick the urine on every visit. We also monitor the calcium-creatinine ratio in the urine, because increased calcium excretion is common on the diet and puts you at increased risk of developing stones. Some units would do regular renal ultrasounds. We would tend to ultrasound if we had a consistently elevated ratio or the children were on topiramate or zonisamide, putting them at extra risk. Potassium citrate is used by some teams routinely. We would tend to use potassium citrate, which alkalizes the urine and is said to reduce the risk of precipitation and stones, although that's not true of every type of stone. We would consider using it if potassium supplementation was required in the diet. So rather than giving potassium chloride, we would give potassium citrate instead. And also if the calcium-creatinine ratio was elevated. Moving on to think about bones. Bergquist in 2008 measured bone mineral content every 3 months for 15 months using a DEXA scan, which is a type of X-ray measurement that you can use to look at mineral density within bones, in 25 pre-pubertal children. And I think the first thing to notice is that at time 0, so at the start, before they'd even commenced the diet, we have bone mineral contents which are below normal. Now, the score here is called a Z score. Apologies to those of you who already understand that, but in case there's anybody thinking what on earth is a Z score in the audience, a Z score is the number of standard deviations below normal or above normal that your particular measurement is. So a Z score of minus 1.47 means that on average in that group, the bone mineral content for height was 1.5 standard deviations below average. Okay? That was at the start. After 15 months, the bone mineral content for height had fallen to minus 2.2, more or less, standard deviations below. And that was also true of the bone mineral content for spine, and was also true of height. Minus 0.31 standard deviations at time 0, and minus 1.4. Why, you might say, were they low to start with? It's probably a number of reasons. A lot of the children had additional impairments, which can impair growth, such as posture and movement disorders like cerebral palsy. And a lot of the children will be on chronic anticonvulsant medication, which again we know can be associated with osteopenia. And what they found was that bone mineral content and height declined by half a Z score, half a standard deviation per year, despite being on fewer anticonvulsant drugs and despite being supplemented with vitamin D. This finding persisted after they corrected for age and height. So bone mineral content changes with age, so you put a correction in to make sure that that doesn't explain your effect. Bone mineral content also changes with height, and looking at that raw data, you might say, well, if they're not growing and they're not getting taller, they're not getting more bone mineral content, that explains it. But in fact, when both of those things were put in and corrected for, the finding persisted. In this particular study, 84% of the children were ambulant, and 32% of them had cerebral palsy of some sort. The most at risk for the reduction of bone mineral content from their study were younger children and non-ambulant children, and those with a poor BMI status. A further study looked at the impact on growth and resting energy expenditure in children with intractable epilepsy on the diet, and they found that resting energy expenditure didn't change, but linear growth declined over 15 months once again. The adjusted height Z scores decreased from baseline to 3 months and 15 months, indicating a height velocity deceleration. So we must measure length in our clinics. A more recent study from the Australian group looked again at the effect on the developing skeleton. And they looked at 29 patients who were on the ketogenic diet for a minimum of 6 months, but there's quite a large range there of up to 6 years. The median age at initiation was 6.5, but again, there's quite a big range of ages there. They again looked at DEXA scans, but also looked at bone mineral density as well as bone mineral content. And there are arguments for and against doing that in growing children. But a density is, of course, the content you have per unit volume of bone, rather than in a particular selected area. And they looked at it in the right hip and in the lumbar spine. Again, calculated the Z scores, which is a way for us to reference our population against control data. And also looked at some biochemical markers of bone health and bone turnover to see if they changed. Interestingly, once again, when you look at the bone mineral density Z scores for the population as a whole, 0 would be average, and you can see that this population is anything up to -2 already at the beginning. Okay. Interestingly, the Australian group then looked at their population mobility, and they did that by using the gross motor function classification score, which is called the GMFCS score, which is a score to grade mobility in children with cerebral palsy, with 1 being virtually normal unaided mobility and 5 being fully dependent on chairs for mobility with limited head and truncal control. And what you can see is that in the children with near normal mobility, actually, they pop up here at baseline, near normal, and for those with varying degrees of impairment of mobility, they already start off with lower bone mineral density. And that's something that we know from clinical practice. When we look at children with cerebral palsy and we x-ray their bones, for a particular reason, such as they may have had a knock or some other accident, we look generally at their bones and they look thin. A rather surprising finding, though, that came out of this study was that when they looked at the near normal group for mobility, the rate at which the bone mineral density content reduced over time, so we have 0, 2 years, 4 years, and 6 years, the rate of bone mineral density loss over time was greater in the more mobile group, and although it started at a much lower baseline in the children with impaired mobility, the rate of change in terms of the rate of loss seemed less. On average, they did show 0.16 standard deviation loss per year in terms of bone mineral density. But, we're left thinking, why are the rates of loss of bone mineral density greater in the ambulant children, which is not what perhaps we would expect? And I don't think we know the answer to that. But what we know about bone health, or the state of bones, is it's an ongoing conversation. A bone isn't a bone, and that's a bone, and that's the end of it. We know that there's osteoblastic activity, osteoclastic activity, and there is a constant conversation of bone modelling and mineralisation going on. And the question is, I suppose, if there's a bigger conversation going on and you add an intervention, do you have more potential to affect the conversation than if there's less of a conversation going on because there's less bone turnover in those who are less mobile? That's speculative. I don't think we know the answer to that. And small numbers and confounding factors in this study, such as their height, their pubertal status, the big age range that you had, and their nutritional status, I think merely suggests to us that a larger study would be required to look further into that. But I thought it was an interesting finding. Then, what happens to growth in all of this? After we stop the diet, what happens to growth then? And a group from Korea looked at the catch-up growth after weaning from the diet and whether or not it occurred. And they looked at 40 individuals on the classical diet, again with quite a big age range, and they looked at Z-scores, again on height, weight and body mass index, baseline 2 years into the diet and 1 year after the diet was discontinued. And although this all looks like a load of spaghetti lines to some extent, what I've put down at the bottom, this is baseline, this is height, and these are the Z-scores. So 0 is average, -1 standard deviation, -2 standard deviations. And this is baseline, 2 years, 1 year off the diet. And what you can see, and same for weight, and what you can see here is that from baseline to 2 years in terms of height, there is a marked decline in height velocity. P0 means the probability of that happening by chance is virtually 0, which means it's highly significant. But when you look to baseline compared with 1 year off the diet, that effect has disappeared. So you've got a kind of 50-50 chance that would have happened by chance, so that is not significant. And you can actually see that what the lines do, which is encouraging. So there is catch-up growth. In terms of weight, it is significant. There was a significant loss of weight 2 years after the diet, and then 1 year off the diet, most have increased again. And although the probability of that happening by chance is still small, we tend to use a cutoff of P 0.05, 5% chance that would have happened by chance. So that is not significant. So the effect is much more significant for height. They also found that walking, ambulation, had a favourable effect on growth during the ketogenic diet and after it was discontinued. And that uncontrolled epilepsy and younger age at the start of the diet was associated with a negative effect on growth. And whether or not that was associated with other impairments, more anticonvulsant drugs in cocktails and their negative effect on bones, probably all of the above. So why do these effects occur on bone and growth? Well, to a certain extent, people have thought that acidosis might play a part. In most of the children, if you actually measure their pH, it's within the normal range, and the body will take any action required to maintain a normal pH. It is the last thing to go, if you see what I mean, when you're unwell, because all of our organs don't function well outside a normal pH. But sometimes you do see low bicarbonates. You know, they're tacking along at the lower end of normal or just under normal. And when that happens, when you have an acidotic environment in blood, you tend to leach calcium out of the bony matrix. And then once it comes out of the bony matrix, you tend to wee it out in your urine, which is why you have an elevated calcium-creatinine ratio. So does this acidosis of leaching it out and then excreting it in your urine have something to do with the effects on bone? Probably. We also know that an important hormone for growth called IGF-1 alpha is suppressed during the use of the ketogenic diet. The effect is probably multifactorial. I don't think we've got to the bottom of it. As yet, we don't have any definitive data on the modified diet. And there's a lot of variation in the use of these DEXA scans. So the question is, should we be doing regular DEXA scans on our children? It's radiation. Is it going to change your management? I think if you're doing a research study or you're trying to answer a particular question, the answer would be yes. In clinical practice, I think I know what's going to happen. I've just showed you what happens. We would tend to limit our use of the ketogenic diet to 2 years and review. That doesn't mean they have to come off it at 2 years, but we review the need for it and try to persuade a trial coming off the diet after 2 years. So in the first 2 years, I know that bone mineral content is going to go down. I know there's a significant risk of height velocity slowing down. I know that we're going to supplement vitamin D. I know I'm going to make sure their calcium and their phosphate are normal. I know I'm going to recommend more standing in their standing frame and as much ambulation as possible. So how is doing a DEXA scan going to alter my medical management of this child? My approach at the moment is it's not, so I don't do it. I think beyond 2 years, if they stay on it long term, I'm quite happy to get a baseline at 2 years and then take it from there, because it may inform the conversation going forwards in terms of a significant drop-off in bone mineral content for those staying longer on the diet, and it may inform us if they start to get fractures. I'm sure if you ask a different paediatric neurologist, you will get a different answer. So the other thing people worry about with this diet is cardiovascular risk factors. And actually, your Klepper's group looked at 10 patients who'd been on the diet for 10 years for GLUT1 to just look at the incidence of complications. And although this looks like a complicated diagram, basically it summarizes the findings. So this is BMI up here, and these are standard deviation scores again. And on each of these diagrams, the dotted line represents the danger zone for the particular measurement. So this is 2 standard deviations above what would be a desirable BMI, so that's your danger zone. Yeah. With high density lipoproteins, we like those. Minus 2 standard deviations in your high density lipoprotein would be a danger zone, so your dotted line is down there at -2. Triglycerides, we don't like those to be high, so your danger zone is there. Total cholesterol, we don't like that to be high. And low density lipoproteins, we don't like them to be high. So the dotted lines represent don't want to go there area. And then when you look at each of these parameters at before the diet, 6 months, 1 year, 2 years, 5 years, 10 years, what you can see is that over the long term, over the short term, you can get some fluctuations, which never quite, put you into a danger area that you're going to get very panicky about. Maybe 1 or 2 patients cause you a bit of anxiety. There are genetic factors for some of these patients as well, of course. But the take-home message is that after 10 years, all of the measurements were basically what they were at baseline, which is good news. And there was no change in the carotid artery lining thickness, which they measured, which can be a measure of whether or not you're developing plaques or narrowing of your artery in your neck. And there was no change in blood pressure. So that data is quite encouraging and is more long-term than a lot of the other data that we have. So the Johns Hopkins group looked at this in their modified Atkins diet group in adults. And they did all sorts of measures as well as various lipid panels. They also looked at the carotid intermedia thickness and plaque presence. And they looked at it in 20 patients who'd been on the diet for more than a year, started as an adult, versus 21 adult patients with epilepsy who were naive to the diet. We don't expect children to have arterial narrowing and these sorts of things, but of course when you look at the adult population it becomes even more important to look at a control group, because sadly as we all get older we all do fall victim to these kinds of things anyway. And those treated with the modified Atkins diet had lower weight, lower body mass index, waist, hip circumference, percentage body fat, and serum triglyceride levels. All good news. They had higher serum levels of small, low-density lipoprotein particles and were more likely to have a pattern where those small particles predominate. There was no difference in the lining of the carotid artery in terms of thickness or in plaque presence. And why does that matter? Well, these small low-density lipoprotein particles cross more easily across the arterial wall. They bind more easily to the lining of your arteries, and they tend to promote damage and dysfunction to the lining of arteries. And this creates an encouraging environment for plaques or atherosclerosis to develop. It is a dyslipidemia associated with premature coronary artery disease and is predictive of an increased risk of heart attack, myocardial infarction. So the role of these lipoprotein subfractions in terms of their cardiovascular risk is a continuing area of investigation. But once we know about that, it gives us the potential to improve the risk assessment in various patients and consider interventions, such as statins, for example. Doesn't necessarily mean coming off the diet. You can manipulate what kind of fractions might be in the blood. Looking at blood vessels, because I've mentioned that a lot, this thickening issue. A study in 2014 looked at 26 children after a year and some after 2 years on the diet using high-resolution ultrasound. They also looked at lipid profiles. They showed that there was a gradual decrease in the capacity of the artery to distend during pulsatile flow. Generally speaking, that's thought to be a bad thing. We like nice, flexible, distensible arteries. There was also an increase in some of the unhelpful lipids at 3 and 12 months. But these differences were not significant at 24 months. So it looks like there's some kind of shift that occurs that is temporary, and then the body may adapt. In terms of rarer side effects, pancreatitis has been described. It's very rare. The mechanism is unknown. And long QT syndrome and cardiomyopathy have been reported. So long QT syndrome is one of the intervals that you can measure on an electrocardiogram of the heart. And it puts you, if you have a long QT syndrome, it puts you at increased risk of arrhythmias. So that and heart muscle dysfunction, cardiomyopathy, have been described, but they've been in association with selenium deficiency and also with pyruvate dehydrogenase deficiency, which in and of itself can be associated with cardiomyopathy. So moving briefly onto monitoring, there is that monitoring that we do at in hospital and that which the parents do at home. And I'm sure you're all familiar with these types of monitors, which we hand out to families with training on how to use them. Some centres still prefer urinary ketone monitoring. It has advantages, namely that you don't have to prick your child with a sharp stiletto to get a drop of blood, which some families find difficult. The disadvantages are that children may pass urine infrequently, particularly those with additional impairments. And when they finally do produce urine, that's then not a reflection of the state of ketosis at that time, because we don't know how long it's been in there, and the urine is subject to dilutional and concentrating effects. Blood ketone measurement tests beta-hydroxybutyrate, whereas urine tests acetoacetate. The advantages are that it's immediate, it's accurate, and you can schedule the tests to fit in with the family and the child. You can answer the question on the spot about whether or not ketosis has been achieved, and has adequate ketosis, which I put in quotes because that is an individually tailored decision about what is adequate for that child, whether or not that has been achieved. Or, in the situation where the child is looking a bit peaky, a bit pasty, a bit flushed and a bit sweaty, is there excess ketosis that requires treatment? The disadvantages are that it's a blood test, and some children and parents struggle with that. The strips are expensive, and it does take some skill to become good with the lancet and get a nice, decent-sized sample. We also ask them to do blood glucose measurements, but they are most important for safety reasons rather than continued monitoring at the moment, at diet initiation, or if the child looks unwell. The frequency of how often you ask parents to monitor varies between centres and probably is a bit dependent upon age. We tend to monitor more frequently in younger children and during dietary introduction or any adjustments that have just been made. Again, during intercurrent illness or if the child looks unwell, that is a time when the parents would monitor. At introduction or during major adjustments to the diet, we would tend to advise twice daily for a few days, then back to twice weekly if they're stable. Again, it's all very well teaching them how to monitor, but you then have to give them a plan about what to do with the results. In hospital, well, there have been 2 documents published. This one in 2009 by the ILAE on the optimal clinical management of children receiving the diet, and we are expecting a second version of that document imminently. And then a further document which was published, which are okay, well, this is all fine with the all singing, all dancing Western world. But what do we do if we're not in the Western world and we are in a limited resource setting? Is there any way that we can, be comfortable with these children going on the diet and be comfortable with a level of monitoring, which means that these children have access to this treatment? And there was a further document published on what might be the minimum standards. To summarise what's in those documents, height and weight, you can tell from the data I've presented, are mandatory. Reviewing their home readings and the need for any adjustment of the emergency care plan would be another routine thing that we would do in clinic. Develop a protocol for checking the blood tests every 3 to 6 months, which would largely be in line with what these documents suggest. And we would do 6 monthly ECGs because of the potential for the effects on the heart tracing, and a renal ultrasound, as I described, where indicated. This is by no means comprehensive, but this list represents more or less what is in these documents. Those tests with an M in brackets are mandatory, and those tests with an A in brackets are advised. And clearly, if you were in a resource-poor setting, you may not be able to do the advised tests, but the mandatory tests are recommended. So in summary then, the ketogenic diet is well tolerated. Most side effects are minor and can be managed. The early potential serious side effects, such as hyperketosis and hypoglycemia, can be monitored and treated, and adjustments can be made as necessary. The longer-term side effects can also be monitored and can also be treated, and a protocol-driven approach can be useful to keep everyone on track in terms of monitoring. Thank you.